Hi everybody, welcome to Healthline. I am Gregory Zarian. Okay, so summer is coming up. We are in the middle of spring. Hope you had a great Easter. As spring is upon us and we are heading into summer, that means some of the sweaters are coming off. We're taking off the jackets. We're spending more time outside. And as I always invite you to do, get up, get out, get off the computer, turn off the TV. Get off your iPad, leave your phone, and just get up and go outside, find some friends, take your dog, ask your parents, or even go on your own and just go out and breathe and go for a hike, go to the beach, go for a walk. Just for so long, we were stuck inside. For over 3 years, we were dealing with this pandemic and we just stopped living. We are now going back outside more. We're experiencing more. I'm not saying I'm not saying do not wear your mask, do not wash your hands, do not do what you need to do to be as healthy for you and the people you love, but just, we kind of woke up and we are doing more and living again in just a healthier way. However, for the past couple of years, as we didn't know what we were doing and didn't have all the answers, we were inside. We weren't as active and as healthy, and a lot of us had put on weight. And what did you do? How are you taking it off? How are you letting it go? How are you getting rid of it? Are you doing fad diets? Are you doing shakes? Are you doing fasting? There are so many options out there. Are they healthy? And there are those that actually end up going to a surgeon's office to have bariatric surgery. That is the topic for the day. So joining us from Adventist Health Glendale is Dr. Noah Swann, and he's going to tell us everything we need to know about whether or not you are a candidate, how it works, why it works, and we're also going to talk about the new craze called Ozempic. Hi, Doc.
Hi, Gregory. Thank you so much for having me today.
No, so great to have you here. How was that to hear my intro in regards to just people getting up and getting out again?
Well, we know that obesity is multifactorial, associated with heavy genetic components and dietary components as well. But one thing that everyone does have the ability to affect is how energetic and how much energy they have and how much activity they do on a regular basis. And while we're reluctant to tell people that they're obese or gaining weight because they're not doing enough exercise, because of how challenging all of our lives are, I think we can all sort of take a step back and realize that we can become healthier versions of ourselves through regular exercise, and that intervention alone can increase our metabolic rate and mean that we consume calories essentially faster at that point.
Okay, that was so great. Okay, we're already at our first break because I talk far too much. More Dr. Swann when we come back. And here's the thing. Get up, do about 20 jumping jacks, have a glass of water, and maybe grab an apple, and we'll see you on the other side. Don't go away. Welcome back. I'm Gregory Zarian, and this is Healthline. Joining us from Adventist Health Glendale is Dr. Noah Swann. Conversation is all about bariatric surgery. Mm-hmm. And before we talk about the procedure, who's eligible, who's not, and to the patient that you would say no to, actually, in regards to just living a healthy lifestyle, what is your invitation to all of us?
I think that the most important thing is getting up and moving regularly. And there have been lots of studies that have shown that doing small amounts of activity multiple times during the course of the day can keep your metabolism going and kind of kickstart that from happening. I was really impressed earlier that you emphasized getting outside and being active, because that's something that everyone can do. You don't need a gym membership. You can just walk. And that can make a big difference in terms of using the calories that you consume over the course of the day versus storing them as fat.
Well, yes, and what a lot of people also say, well, I work full time, or I'm inside, or I'm outside. And one thing, even for the past couple of years, is we were not locked in our homes. Yeah. We stayed in our homes because we were navigating through something that we have learned more of. Yeah. Get up and get out, take walks, and it's not just this easy saunter. It's just about one day walk a block, the next day walk 2 blocks. A girlfriend of mine, years ago, she had put on like 40 pounds. Yeah. And she said, I don't know how I did this. And I'm like, well, I could tell you. And lack of exercise, eating poorly, and she goes, what do? I said, let's take a walk. And I said, tomorrow, take another walk. And just to add on a block every day, because if you get up and run that marathon, you're gonna go too far, too quickly, all at once, instead of baby steps. My friend lost 60 pounds.
And that's
because
a common
one block turned into many.
A common mistake people make when they start trying to do an exercise regimen is to jumping into something that's too intense or that can be scary to them. And by far and away, the most important thing with exercise is doing it regularly. And whatever it takes to maintain that regularity is really the best thing for people overall. I will caution you, though, that it's very tempting to think that obesity is an individual's fault. And it's very easy to blame lack of exercise or dietary choices that individuals make in terms of determining what their BMI is going to be. And
can you real quickly share with us what the BMI means?
So BMI means body mass index, and it's a number that it's not perfect for designing, for determining obesity, but you look at your weight over your height squared in metric numbers. And we consider a normal BMI to be between 18.5 and 25. Anywhere between 25 and 30 is overweight, and you enter into that obese category when you get to a BMI of 30 or higher. And we know for patients, once they reach a BMI of 30 or especially 35, that diet and exercise alone and modifying those are generally not sufficient to maintain adequate weight loss long term. And that's really where I think bariatric surgery becomes such a powerful tool, is it can help people who are trying to do the right things but not seeing the success that they're hoping for to get over that hump in terms of losing weight.
Absolutely. One thing too that I think people need to do is also talk to their family about medical history, genetics. Ask questions. Ask 1,000 questions about, was Nana overweight? And one thing you said too about the word obese. Don't be afraid of the word. You could be barely tipping over the 30 of the BMI. Yeah. And bottom line is, I was studying this morning, and we are considered the fattest, not obese, the fattest country in the world, which is saddening to me, because you see that we are all about working out and exercise and all these fads and work things, but we're also lazy and we don't do what we need to do. So for somebody that is watching this and they are just not motivated and don't have the intention to get up and get out, because some people love it, some people don't, what do you say to them, and how do you invite someone to get up and become more healthier?
Well, by the time patients have made it to my office, they've normally tried multiple rounds of diet and exercise without success, and at that point they're referred to a surgeon for considering surgical weight loss. And I really impress upon them the fact that bariatric surgery is not a cure for obesity. I'm giving you a very powerful tool, not just to lose weight, but also treat or prevent things like hypertension or diabetes. But it's incumbent upon each individual to use that tool, and that means following the dietary modification, small frequent meals throughout the day, high protein, low carbohydrate, and then, of course, staying active through all of that. And the patients that really take that to heart are the ones that do the best long term. About 20% of patients who have bariatric surgery between 3 and 5 years out will end up regaining half or more of the weight they've lost back. And
why is that?
It's almost always due to poor dietary choices. These surgeries we do are designed to reduce your appetite, make your metabolism a little bit more efficient, so you're using your calories more efficiently. But at the same time, if you eat the wrong things, no amount of surgery is going to overcome that. And so patients need to understand going into surgery that they're committing to themselves, that they're going to modify their diet, maintain a good exercise regimen, but this time compared to prior times when they did diet and exercise, they're going to see better results.
So what do you say, because we're already going to head into our next segment, what do you say to somebody that isn't a candidate for bariatric surgery? Because I know there are people that you doctors will say no to. Somebody wants to just get motivated to get up and get out. What is your invitation to them to get off that couch and just start getting active to get their life back?
I think having a social component to exercise is incredibly important, and joining a group, whether it's a walking group with friends, joining a sports league, those are all very good ways to get an additional motivating component to go to the gym. Beyond that, not making it the biggest deal in the world. So instead of thinking I have to go and do an hour workout, go walk around your block a couple times. And those little interventions can sort of cascade into bigger interventions as you start feeling healthier.
And here's the thing too, though, is also instead of saying I have to, choose the words I want to. And find a group, go to a spin class. And one thing that we've talked about on Healthline for the past 14 years is accountability. Yeah. Hey, I'm going to do this. Hey, let's do this together. I want to. Hey, let's do it. And then if you work in offices and if you have a 9 to 5, get up every 10 minutes and just move around the floors, walk up and down, if there's stairs. I'm sorry, ladies, if you're wearing heels, put sneakers on because they do it in New York and walk up and down, walk around the block, cut your lunch in half. Instead of 4 sodas a day, start with getting rid of 1 and then turn that into a glass of water, and really baby steps so you don't shoot for up here and then you miss everything in between, because there's something there's something fantastic about feeling your body change. I've lost 35 pounds, have kept it off, give or take the 5 to 7 pound dance, which I think most of us do. And instead of me having that extra donut last night, I thought I'm gonna have a glass of water. And you talk yourself off the edge and you become kind to yourself. You don't call yourself names. You don't hurt yourself. You don't, verbally assault yourself on how bad you look. Celebrate the choices that you're making to live a healthier lifestyle. Okay, I'm off that second soapbox. More with Dr. Swann when we come back. Don't go away. Welcome back. The conversation's all about bariatric surgery. And joining us from Adventist Health Glendale is Dr. Noah Swann. Doctor, so who qualifies for bariatric surgery?
So the qualification is determined based on your BMI, as we discussed in the prior segment. And anyone with a BMI of 40 or higher qualifies for bariatric surgery. And there's a subset of people who have a BMI of 35 with qualifying medical comorbidities like diabetes or hypertension that also qualify for the operation.
Because the surgery would make the diabetes and the hypertension
and that's one thing,
go down.
If our viewers take away one thing from this conversation, it's that bariatric surgeries are not just weight loss operations. They're really designed to improve your metabolic health overall and treat things like diabetes and hypertension.
I love that.
And as a result, if a patient with a BMI of 40 gets a bariatric surgery when they're 30 years old, they're going to see meaningful improvements in their quality of life and reduction in comorbidities, and long-term add about 4 to 7 life years. And so we're, through our surgeries, giving patients longer, better qualities of lives, and I find that to be really meaningful.
When do you say no to somebody that comes into your office that wants the procedure?
So in order to qualify for surgery, you need to meet those thresholds. And there are patients that don't, and they have the option of trying non-surgical weight loss methods. Sometimes the natural course of time means that they'll gain a couple pounds and qualify. What really disqualifies patients are decisions that they make. So if we have patients that are alcoholics or heavy smokers, those are things that can lead to significant complications after bariatric surgery, more so than with a regular patient. So you can have higher rates of cirrhosis with alcohol consumption following bariatric surgery. And then anytime we operate on the GI tract, there's opportunities for leakages or ulcerations to happen, and things that reduce oxygen content in your blood, namely smoking, dramatically increase those possibilities. And so these aren't hard contraindications that all surgeons use, but if patients are heavy smokers, I advise them to go through smoking cessation programs prior to bariatric surgery, knowing that their outcomes are going to be significantly better afterwards if they're able to do that.
I love that. So smokers and drinkers, you know who we're talking to. So somebody is approved to have a bariatric procedure by you. Mm-hmm. What is the procedure? What is the build-up time to the procedure? And what is the recovery time?
So everyone has to go through some of the same preoperative workup that's mandated by insurances. You have to see a psychologist one time, and you have to see a nutritionist. And normally that's multiple visits with a nutritionist.
Which I love.
And that was initially designed to make sure that patients would develop healthy eating habits before bariatric surgery. We talked a little bit previously about how eating unhealthy carbohydrates or overeating or binge eating in general, despite bariatric surgery, can lead to additional weight gain. So we try to address those things before the operation happens. happens. And then bariatric surgery is incredibly safe these days because we do a diligent preoperative workup with other specialists. So if you need to see a cardiologist or if you need to see a pulmonologist before surgery, we recommend that you go see them first. A large percentage of our patients are diabetic, and so their A1C, which is a long-term marker of their blood sugar, we look at that knowing that if it's too high, it actually leads to complications down the line. And so we ask those patients to modify their blood sugar or medications before surgery and preparation. Because there's so much variability in that time frame, it can take anywhere between 3 months and up to a year to get to bariatric surgery. And during that time, we also have a weight loss goal that we set for our patients. And typically that goal is within about 10 to 15 pound range, but sometimes we have very large patients where it goes up to 50 pounds. And the reason there is to shrink the liver, which shrinks faster than the rest of your body when you lose weight. And that liver is directly on top of the stomach where we're operating, so it makes it safer to do the operation when that shrinks down. And just to go back to what you asked about earlier, that's one of the reasons why bariatric surgeries may get delayed or canceled prior to surgery, is if patients actually gain weight as opposed to lose weight during that interval, it can make it overly challenging and dangerous to do the operation, and so we sometimes have to delay it then. But once they get through all of that preoperative workup, you'll do a clear liquid diet for about 2 weeks prior to surgery. Patients typically lose about 5 to 10 pounds during that period, and then after surgery, they'll stay on that clear liquid diet for the next 2 weeks.
But the setup, though, the pre-op chunk of time is also to see if somebody's really ready and willing and wanting to do
Absolutely.
the work.
You know, people should not enter into bariatric surgery as a light commitment, because it does dramatically change the way that you're able to interact and eat food moving forward. And so I think insurances and physicians have realized that it's important that we make patients really consider the implications of the surgery, think about how it's going to change their lifestyle, and make sure that they're ready for that before we intervene with an operation.
So what exactly is the surgery?
So I do 2 major bariatric operations. I do a sleeve gastrectomy and I do the gastric bypass. The sleeve gastrectomy is the simpler operation. It takes about an hour to perform, and on average it's a 1-night stay in the hospital. And what I do is I use a surgical stapler and I remove 80 to 85% of your stomach, leaving your stomach about the size of a banana afterwards.
Okay.
And the surgery helps you lose weight in 2 ways. There's portion control that comes from the small stomach. And one of the aspects of having the surgery afterwards is that if you do try to overeat, it gets uncomfortable, and sometimes patients vomit afterwards. And so it's really important that patients know what they're getting themselves into, and that we identify things like overeating or binge eating prior to surgery, because those can be problems afterwards. The patients typically lose about 60 to 65% of their excess body weight a year and a half after a sleeve gastrectomy. So your excess body weight is everything on top of your ideal body weight at a BMI of 25. So that's a very favorable result. And the nice thing about the sleeve is that it doesn't have significant long-term complications. So what we worry about long-term for these patients is worsening acid reflux. If you have moderate to severe acid reflux beforehand, by making the stomach smaller and higher pressure, then you can make that reflux worse. And so that's one of the reasons we consider the gastric bypass instead of the sleeve as our other operation.
We're going to hold on to the gastric bypass. More Dr. Swann when we come back. Don't go away. Welcome back. Did you know that Adventist Health Glendale is ranked among the best hospitals in America, earning 3 straight 5-star ratings from the Centers for Medicare and Medicaid Services, and our 16th straight A grade for patient safety from the Leapfrog Group? Joining us from Adventist Health Glendale is Dr. Noah Swann. Doctor, you just talked about the bypass, the bariatric procedure of the sleeve, and then number 2 is the gastric bypass.
So the gastric bypass is a more dramatic operation that we do. It takes about 2 hours to perform, and on average it's a 2-night stay in the hospital. And we make a small pouch out of the early portion of your stomach and then bring a loop of intestine up. And that's the new pathway that food travels, bypassing the majority of the stomach and the first portion of the small intestine. The intestine's reconnected to itself further down so the digestive juices and the food can mix. And that's why it's called a Roux-en-Y gastric bypass, is that Y connection right there. The gastric bypass offers slightly more weight loss than the sleeve because in addition to the portion control and the appetite control that comes from hormonal changes, you're also bypassing a portion of the intestine and not absorbing any calories there. The added benefit is that because the food goes directly from the small gastric pouch into the intestine, there is significantly less reflux. And so for patients that have obesity and moderate to severe acid reflux, it really is the operation of choice. It's also the gold standard operation for weight loss in the United States because it's been around since the 1970s and it's very well studied. So we know what all of the risks and complications associated with it are.
Real quickly, when you were talking about the sleeve and you said about 60 to 80%, does the stomach grow back?
The stomach doesn't grow back. That's an irreversible portion of the operation. However, if you overeat after a sleeve gastrectomy,
yes.
it can stretch out, and
Stretch.
that can kind of mitigate some of that restrictive effect. And that's one of the reasons why patients can have weight regain after surgery, is that they're able to eat larger quantities.
And a lot of people that end up having one or the other procedures, they know that it is not a quick fix, that it is a new lifestyle choice.
This is something that we're very adamant about in terms of preoperative education, both in our clinic and with our nutritionist. After surgery, you're able to eat 14 to 16 bites long term, and at that point, you should feel full. And to get to that point, there's a transition in the postoperative period. You'll be on a clear liquid diet for a couple weeks after surgery, and then you transition to a full liquid diet for a couple weeks after that. And so really starting about a month after surgery is where you start trying regular foods, and you have to try them one by one.
Sure.
And to sort of see how your new stomach reacts to everything. Long term, we emphasize patients having a high protein, low carbohydrate diet with multiple meals a day.
And when you say carbohydrate, we're talking about donuts, cookies, pastas, and all the things that we can buy in the middle of the market. Because on the outside perimeter are the fruits and produces and vegetables and everything that's quite a bit healthier for you.
That's exactly right. Anything that can easily be digested by your body, and that's not just those sort of bready items that you described, but also things like juices and sodas. Those are by far and away the easiest thing for your body to absorb, but they're also not easy for your body to use. And so that's probably the most important part of the dietary modification, is finding ways to minimize carbohydrates as a part of your meal. One thing I would encourage all of our listeners to consider is the current Western paradigm of a meal includes a large portion of carbohydrates with a small protein on top. And I would think we should turn that plate upside down with a high protein portion and just a small side of carbohydrates. And that's really what we try to encourage our patients to do.
Have a colorful meal.
Yes.
So a second ago you said the word dietary, and what is now sweeping the nation is Ozempic and Wachovia. And up until meeting you, I've heard it's a diabetic drug, but diabetic patients are now saying that it's so high in demand that they can't get their medicine. What are your comments about that?
So they're called GLP-1 agonists, are a relatively new class of drug that was designed for diabetics. GLP-1 is a molecule that, in addition to increasing satiety and then decreasing how quickly your stomach empties, it also increases your sensitivity to insulin. So it kind of works as a synergy with insulin. And these medications, while you're taking them, can mimic a lot of the metabolic effects of bariatric surgery in terms of reducing appetite, increasing your metabolic rate, decreasing your draw to food in general. And they can be very powerful. However, they're only a temporary solution. And what that means is as long as you're using the medication, you're going to continue to see the effects. But they tend to be once weekly injectable drugs. They're relatively expensive to make. If you come off the medications, you often see rebound effects in terms of increased appetite and increased weight gain. I think these are very powerful tools to help patients that are gaining weight during stressful periods of times in their life, or who have gained weight after bariatric surgery. But as a long-term solution for treating obesity, they are a continuous medication that you have to take for the rest of your life, that you have to inject. And over the course of actually a couple months, bariatric surgery becomes, at least from a cost-effective standpoint, a more effective intervention than Ozempic does. Now, in terms of the supply chain shortages, I don't think anyone anticipated how popular these medications were going to be. And in terms of the way that they're made, it takes a long time to ramp up production. And so we are seeing companies like Novo Nordisk significantly increase their production, knowing that physicians are using these medications off-label and now on-label for weight loss. But we still haven't caught up to the point where all insurances are providing them. I know that a lot of Medi-Cal HMOs, for instance, are requiring pre-authorization for these medications. And a large component of that is the cost, and knowing that it's very tempting as a physician to put your patients on these medications because they are a good, relatively easy fix. But there's some resistance from payers, knowing how that they'll have to be a long-term commitment.
And also one thing I want to throw out there before I want to get your final thought is bariatric surgery, the sleeve gastro bypass, Ozempic, and all these other options. They're not recreational. These are lifestyle choices that it's a commitment. And it's not just something that you're going to give yourself a shot every couple of weeks and boom, you've dropped the weight. It's something that you, as my doctor, would have a heart-to-heart conversation with. Because a lot of people come in and they want the quick fix, and then they come back to you and be like, well, listen, I put on 40 pounds, and they look at you, and we have to take this seriously. What are your final thoughts in regards to health and wellness and all of us being at our best BMI and healthiest?
I think it's important to, consider that BMI is just a number. It's not who you are as a person, and that number is imperfect and can represent different things for different people in terms of height, in terms of muscle mass, in terms of genetics. In the immediacy, I think the most important thing is trying to be the healthiest version of yourself, and that means having healthy habits that you enjoy, and finding the joy in what you eat and what you do on a regular basis makes it significantly more repeatable and more sustainable. And I think for our listeners, that's the most important thing, is being able to sustain long-term success with diet and exercise regimens.
And what you said is also enjoy it.
Yeah.
Doctor, it's such a pleasure having you here. Thank you
Gregory,
so much.
thank you so much for having me.
So you heard it from Dr. Swann. It's a lifestyle choice. Going to see Dr. Swann. It's not a quick fix. It's about you being the healthiest you can be. That's the only thing I wish on all of us here from Healthline. The most important conversation you're going to have is about you and your health, so why not start talking now? Take care. Be safe, and we'll see you next time. Thanks.